Emperor Preserve. This is not a fairy tale. This is actually a huge clinical trial that showed for the first time that if people that have congestive heart failure, which we're going to spend some time talking about how to define that as their primary illness, that giving an SGLT2 receptor antagonist, in this case was called Jardiance, one of three available in Canada, decreased hospitalization for congestive heart failure. So pretty exciting trial, and it's a trial we got to participate as well. So I'm really excited. I'm going to let Frank take over and tell us what's going to be happening, Frank.
Yeah, so in today's presentation, we're going to start a little bit talking about heart failure, but a specific subtype of heart failure that the Emperor Preserve trial was looking at, which is HFpEF, and we'll define that a little bit later on. And then we're going to look at BNP and NT BNP and other ways that you can kind of like track your heart failure and track that kind of status. Then we're going to be looking at the Emperor Preserve trial itself and the treatment that we're using to essentially improve outcome for.
Why don't we just advance the next slide there, Stuart?
Oh, there we go. Okay, so yeah, so we're also going to be talking about our CHF YouTube. So to begin, we have like a YouTube series on congestive heart failure. So please go ahead and take a look about congestive heart failure and all the videos that we have in the past that talks about the different categories of heart failure, exercise, and everything that you can talk about there. So if you want some background on it, you can find it there.
So congestive heart failure, if you just backtrack one slide, is unfortunately probably the leading cause of how people are going to die in Canada as we get older. And is that so one of the things is how to prevent it, how to treat it, with medications, with lifestyle changes, so much about this. This is really a series of videos that if you're short of breath and you think you have a problem with your heart, so the heart can basically fail in two ways. It can get weak, be damaged, let's say from a heart attack or from alcohol, from a virus, from COVID, other forms of viral infections, from too much, too high blood pressure. So you can actually cause the heart to fail in that mechanism. But more importantly, the heart can get stiff. It's also an elastic band, so it can work at a higher pressure. And that's what the heart failure preserve is. So go ahead there, Frank. Tell some more.
All right, yeah.
So
we've had, so we've had 4 webinars in the past. We've talked about what congestive heart failure is. We talked about the types, medications, treatments, management, and also lifestyle changes for CHF management. And recently, we just also did another one about the Kansas City cardiomyopathy questionnaire, which we'll also bring up a little bit later. It's a great way for you to track your heart failure status.
But first, I see Philip and his wife there. I think they're exercising during the webinar right now. So they practice what they preach. Those are 2 semi-retired doctors that are really looking after themselves, and we should all do the same too as well. So there's something I hear them. I'm going biking with them. I love their conversations, and I'm glad they can join us. And go ahead.
Yeah. So we're going to start off by introducing HFpEF. So what is HFpEF? And essentially, we can define HFpEF as heart failure with preserved ejection fraction. And it can also be referred to as diastolic heart failure. And it causes almost 1/2 of all of the 5 million cases of heart failure in the United States. It's more common among older patients and women, and it results from abnormalities when the ventricles of your heart relax, and it results from passive ventricular compliance. And this can lead to your heart not being able to pump as well, which makes it harder for your heart to function properly. Survival with heart failure, with a specific type of heart failure, is pretty poor. And this type of heart failure is also really associated with high hospital and also high hospitalization and also short-term and long-term mortality rates. So hospitalization, like I said, occurs in 50% of all of these patients. And it's actually around 20 out of all of these 50% of patients, around 35 to 40%, only around 35 to 40% will actually survive within 5 years of hospitalization. So definitely, it's like a really important thing to be keeping track of. Otherwise, you might end up in that group of people that's in the 50% hospitalization. And if you're at that point, you only have 35% chance of survival. And not to scare you, but that's just the facts. So, so now I just want to talk about like what is, and from a physiological standpoint, what this like diastolic heart failure is. And first I want to explain what ejection fraction is. So ejection fraction is essentially how much blood inside the ventricle is being pumped out. Typically, the left ventricle of your heart can squeeze and pump some, but not all of the blood in the ventricle out to your body. A normal ejection fraction is more than 55%. And that means that 55% of the total blood in the left ventricle is being pumped out with each heartbeat. But heart failure with preserved ejection fraction happens when the left ventricle is not filling with blood as well as normal, and the ventricle can pump, but it might be so stiff that it can't relax and fill with blood the way it should be. And this ejection fraction just becomes around 50%. HFpEF may also be diagnosed if the ejection fraction is really low, so it's around 40 to 49%. So the heart can still pump, but it just is not filling as well.
So it's kind of interesting, Frank, is that when someone says their ejection fraction is, let's say, 58%, people get nervous. No, that's normal. Is that, you know, your heart has to be efficient. It doesn't squeeze out all the blood, it squeeze out a good part of the blood. So remember, if your ejection fraction, or if you, as you well point out, if it's over 55%, that's normal. At one time we used, and we talked about in the other videos as well, that systolic dysfunction, once your ejection fraction is less than 30%, you have a much higher mortality as well. And we have something called mid-range, somewhere between 40 and 55%. So heart failure is defined right now, I think, is at risk. And I love your video that you did about how, you know, preventing heart failure. We'll talk a little bit about that as well. So if you have high blood pressure, overweight, you don't exercise, your heart gets stiff and it wears out quick. It works at a higher filling pressure. If your ejection fraction is less than 40% or so, we have certain therapies. Above that, we have certain therapies too as well. And we have this mid-range ejection fraction. So we're learning a lot and we're defining it much better. And one of the things is that I'm in my search for heart failure now much more aggressively because we have a lot to offer people. Thanks a lot. So I love your videos. And remember, normal amount of blood that's ejected each heartbeat is above 55%. Thanks.
Yeah, and to add on to that, heart failure with preserved ejection fraction can often occur because the left ventricle muscle becomes very stiff, thickened. And to compensate for that stiff heart muscle, your heart has to kind of increase that pressure inside the ventricle to properly fill the ventricle. And this increased filling can cause the blood to build up inside the left atrium and eventually into the lungs, and this can lead to fluid congestions and the symptoms that you have of heart failure.
So perfect. What happens, you mentioned the pressure is going up, so the heart's working at a higher pressure. And that's how it's wearing out. So it's a stiff, thicken, get some scar tissue in there. Absolutely. So most of us have a combination of both types. Is that, you know, if you have a heart attack, it weakens the heart muscle. It's called reduced ejection fraction. But as we get older, we lose elasticity of the heart. And the best way to keep elasticity is to exercise, keep skinny, keep your blood pressure nice and low. Thanks for sharing that. Next slide, please.
Yeah. So yeah, as we mentioned in the last slide, heart failure with preserved ejection fraction occurs when that left ventricle doesn't fill with blood as well. And this can be because it's too stiff, but it can also be because it's too thick. And this thickness can come from hypertrophy. An analogy that I kind of like thinking about is like lifting weights. So in the bottom left, you can see someone doing arm curls and they're building their muscles, their biceps, and making them bigger because they're lifting against a resistance, and the resistance is a weight. But the heart is also a muscle, and sometimes we forget that. But the left ventricle uses its muscles to contract and push blood to the rest of your body. And if there's a lot of resistance that they're pushing against, for example, if you have plaques in your aorta or you're some sort of artery, what happens is that the muscle will grow and it'll develop and it'll hypertrophy, and that can make it stiff and harder to relax. So that can lead to HFpEF. And typically what can happen is like with diseases like hypertension, this is something that can occur, or diabetes as well. Something also important to note is that heart failure is an insidious syndrome. And this means that heart failure begins before you see the first signs and symptoms of heart failure. This is a graph that shows the lead up to heart failure onset. And there are 4 main stages of heart failure. So you can see in stage A, you are at high risk for heart failure, but you have not yet had any structural heart disease or symptoms. And then in B, stage B, you see that the disease begins to onset, but there are no signs or symptoms yet to present. And because there are no signs or symptoms, it can be hard for you to know sometimes that you really are following this like slippery slope. But then in stage C, that heart disease gets worse, and then you begin to see signs and symptoms appear. And then in stage D, in the final stage, you now begin to see that you start to have refractory heart failure, and you start to need special intervention. As these stages go on, your symptoms will get worse and worse, and the chance of you being able to have preventable heart failure will decrease. So past stages A and B, heart failure is a lot harder to be prevented, but rather we're just trying to treat heart failure progression. So it's really important for us to recognize heart failure signs while we still can to prevent its onset and prevent it with good lifestyle habits.
Kind of interesting, Frank. You see something called ACS, acute coronary syndrome. 40 years ago, when I was a young medical student, if you came in with a big, large heart attack, you went into shock, you went into heart failure, and you died within a day or two. That rarely happens today because you're coming with a heart attack. What happens is we open the vessel up early on. So, time is muscle. Muscle is preventing of congestive heart failure. So we don't see the big bad heart attacks as we did 40 years ago. We still do, but they're much less frequent. And you can see that it takes a lifetime for many of us for the heart to stiffen up and to lose its elasticity. I will say this is that I was at a really good webinar, good talk on people who live forever. And one of the things that people live forever is that they exercise a lot. Exercise is probably one of the most underrated interventions for depression, anxiety, longevity, kidney function, etc., and for heart failure too as well. And we'll explore that a little bit. So the best time to exercise is today.
Yeah, that's a really important point to mention. Exercise is always important for health of any kind, especially heart health. But another way that you can kind of track your heart health, specifically with regards to heart failure, is something called the Kansas City Cardiomyopathy Questionnaire, or the KCCQ. I think we'll talk about it a little bit later as well. But for now, this is just like a really easy questionnaire that you can self-administer, and it's one of the most prominent tools we have to measure heart failure status. And you can do it yourself. We actually have a Google Sheet here that kind of acts like a calculator for you to basically fill out your KCCQ score. And what you can do to fill out your KCCQ score and improve your KCCQ score is to really make sure that you exercise consistently. If you want more information, we have another webinar. It's called Predicting Heart Failure. It should be on the Greg Curnew YouTube channel. Check it out if you're interested. And the questionnaire should be in our YouTube description. The questionnaire basically, oh, sorry, go ahead.
Go ahead. So what I want to say this is a must video for any Canadian who is getting over the age of 50 years of age who are short of breath. So is that I love this Kansas City questionnaire. We'll talk about 0 to 100. You understand what actually means. 0 is you're dead. 100 means you're perfect. And I encourage everybody to fill this out and just have that at baseline. So if you download this sheet, you get the you can actually, it gives you a number. Is that right? Is that what happens, Frank? Do they get an actual scoring system, or do we have to score it for them?
Yeah, so what happens is it's a self-administered tool, so you can just answer a couple questions. So you can put, you can put a check mark or a 1 in specific boxes that ask you, for example, oh, how is your shortness of breath this week compared to last week? And then you rank it from like 1 to 5, like very good to not very good. And then from that, they'll give you a score. If you answer all those questions on the questionnaire, they'll give you a score from 0 to 100. And like you said, 0 is very poor, and 100 is excellent, perfect health.
So again, everybody should do this and then keep track of that score and just send it in to us at drcurnew232@gmail.com or bring it in. This is actually something I think is a fantastic tool. And thanks for creating that. Go ahead.
Yeah, and I just wanted to highlight your KCCQ that you did a while back, the one that you scored 100 out of 100 on. So I guess this is what a good exercise leads you to. If you want to talk a little bit more about that.
I think this is actually something that's important to think about and to make a priority. What I found is that during this pandemic, most people have lost 10 pounds. I've lost 20 pounds, and I didn't, and you know, we're all too busy to exercise. Well, I was too busy to go home last night, but I got up this morning at 6 o'clock and did the wetward stairs before my first patient this morning. So I encourage you to find, and I feel better. Please fill out the QCCQ, the Kansas City Cardiomyopathy Questionnaire. It's a really neat scoring system. I encourage you to look at that, and we can show you ways to get better. Thanks so much. And it's very few exams I get 100% anymore. So there you go.
Okay, awesome. Yeah, so we know about the KCCQ, but there are also other ways that we can kind of track the status of heart failure. So one of those examples is something called brain natriuretic peptide. So we're going to be talking a little bit about that. So B-type natriuretic peptide, sorry, I said brain. I don't know why that's on my mind. B-type natriuretic peptide, BNP. These levels they're simple and they're objective measures of cardiac functions. So what BNP is, it's actually a hormone. It's a hormone that's secreted by the ventricles of your heart. So, and it's secreted as a response to if your left ventricle stretches or there's wall tension in that left ventricle. And it helps the body compensate for congestive heart failure by promoting a decrease in blood pressure. So that means that there's less pressure, less resistance that the heart is kind of pumping against. Given its functions, BNP can be a really helpful indicator for diagnosing heart failure with preserved ejection fraction. And according to Harvard Health, a normal BNP level is around 98% accurate in ruling out the diagnosis. So this really allows doctors to check for other conditions that might be causing shortness of breath or fluid retention or other symptoms. So you know that it is actually congestive heart failure.
Actually, Frank, you were right when you said BNP. It actually initially was brain natriuretic polypeptide. It was first discovered in the brain, but it contains a lot of high levels in the heart. And so if we were going to name it today, we'd probably call it HNP, heart natriuretic polypeptide. But because it was discovered in the brain, that's where it got its name from. So yeah, and it's a very interesting hormone assay, and I love this assay, and that's wonderful. I see Angelo join us tonight. That's fantastic. Great. Let's keep moving forward. So tell us a little bit more about it.
Yeah. So in heart failure with preserved ejection fraction, because the left ventricle has stiff and thick walls, it can only fill with like a small amount of blood. And in rapid cases of fluid overload, or if the heart starts beating really fast, the muscle cells of this ventricle wall can be really stretched out. And this happens as the chambers will swell with extra blood that can't be pumped out properly. And this will tense stretched muscle cells. These tense or stretched muscle cells will end up producing extra BNP that goes all the way into your bloodstream. And because it's in your bloodstream, this is why high BNP levels are often used as an indicator for HFpEF. So for example, if you do like a blood test, in instances where you're age 50 to 75 and your BNP levels are greater than 300 picograms per milliliter, that would be considered as elevated. Whereas under 100 picograms per milliliter or 200 in some cases is what is considered in the normal range. Simply put, the amount of BNP levels in your bloodstream can tell you how hard or how well your heart is working. And then we also have another indicator or marker that can be used for heart failure, and this is called NT BNP or NT ProBNP. So this is the NT ProB type natriuretic peptide. And this is another hormone that the heart actually releases, and it's very similar to BNP. And studies have found that NT proBNP levels are strongly related to increased left ventricle following pressures. So normal levels of these circulating NT proBNP levels in patients aged 0 to 74 is less than 125 picograms per mils, whereas levels that are less than 450 picograms per mil is more appropriate if you're aged over 75. So there's a little bit of a discrepancy there between those types of different age groups. And then also NT proBNP levels that are higher than 450 picograms in patients under 50 are considered to be elevated, and levels greater than 900 picograms per mils in patients age 50 or older is also considered to be elevated. You can see that in our chart here. And we also, so if you're looking to, how do I get this BNP test or an NT proBNP test? So physicians in Ontario can either order either a BNP test or an NT proBNP test for patients that are experiencing heart failure. And these are just performed through simple blood tests. And they can be performed simply by indicating a test of interest on a patient's requisition form, and then taking that requisition to a lab like Life Labs that offers these types of tests. Unfortunately, these tests are not insured in Ontario, but they can be useful despite the cost that it provides.
So the costs are right now it's $80 in Ontario if you go to Life Labs or Dynacare. You can take BNP multiple by 3, you get roughly proBNP. And what you gave us are the old fashioned or the stuff that are established. And I'm going to show you some more recent information about this. So I think this is a very useful test to tell you a lot about how much time you have left, what your prognosis is. So what I always remember, if your proBNP is greater than 1,000, this unfortunately is a marker for poor outcome. So it some people call it as a marker of deaths, but certainly very manageable. And it also tells you is that sometimes you think a person's shortness of breath comes from congestive heart failure, and if it's very low, it makes heart failure much less likely. So there's lots of things that you mentioned, things that caveats. It tends to rise as we get older, it tends to fall in older as we get more overweight. It rises in kidney dysfunction. And something we didn't talk about right now, atrial fibrillation, it rises. So that's my job to help sort that out. So I wish everybody that is short of breath can get a proBNP or a BNP. I prefer proBNP as a marker. They're both excellent markers, but you have to pay unfortunately around the $80 or so. Next slide, please. So this is actually, so what you gave is to traditional looking at this is actually from the European Cardiology summary on heart failure. And you can see that you have major criteria and minor criteria. So if you look at the middle part, you can see proBNP greater than 220 or BNP greater than 80. A little bit different units than you thought of. And you can see as minor criteria, you can see even lower values, a proBNP of 125 to 220, or BNP 35 to about 80 range. So the numbers you gave is for basically acute decompensated heart failure, but the actual values that you have, you probably have a proBNP well less than 30 at this point in time. So there's different values, and we also look at if you're having heart failure. So other things can cause this too as well. You can have something called pulmonary hypertension that can cause this. You can get this in people that have blood clots in the lungs or having a heart attack. So atrial fibrillation just has separate units on your far right. So the values is sort of a continuum, and we have to sometimes have you're chronically short of breath versus just suddenly short of breath. So that can change the value too as well. If you can see morphologically, one to your left there is that the arrow is going to be pointed there in a sec too. If you can just move the arrow right there, you can see that when the heart changes, the left atrial volume gets increased, the thickness of the heart gets increased. We have echo parameters that get changed, so we can actually measure that, and then we can see your functional status. So I can use an echo machine, my physical findings, your symptoms, there's lots to help diagnose how much structural changes you have in your heart. That's using an echocardiogram. This hormone test adds a lot of value as well. So Frank, the values that you gave there are good values, but lower is even better in that circumstance. Get it added clues over here. So in fact, if I was anybody, I would take a picture of this slide here and just keep it in your wallet or keep it somewhere to help your doctors interpret. So you can see how the field is changing very, very quickly, and very useful markers. Go ahead. Oh, this is another slide. This is another way of scoring for heart failure. You can see we talked about is that the heavier you are, if you have a body mass index over 30, and you're more likely to get 2 points at risk for heart failure. Best body mass index is between 20 and 25. 23 is sort of what you should be aiming for. I'm pretty close to 24, 25 now, so I'm really working hard, and I'm hungry every day of my life, and I will keep exercising, keep eating less, and eating a lot more veggies and lots more beans to try to keep that down. It's a lifelong struggle. It only gets harder as you get older, but if I can do it, you can do it. And I think I work quite a few hours, and I make sure that exercise was a priority. I was hoping to play tennis tonight, but I guess the rain will prevent me. I might do some stairs later on. Again, I did some stairs this morning. Having high blood pressure is also, again, you mentioned that makes the heart work harder. It stiffens the heart. If you're taking 2 blood pressure pills, and people say, well, why do I need another blood pressure pill? But most people with serious high blood pressure take 2 to 4 medications to control blood pressure. So my wish for every Canadian is to have a blood pressure machine. Having atrial fibrillation, a regular heartbeat, means your heart's under stress. Having things like pulmonary hypertension, that's something I have to determine for you. Filling pressure of the F is something I have to determine for you, but what you can determine your age, if you're over the age of 60 years of age. So I get 1 point. I'm 62 years of age on that score system for heart failure. I have a body mass index of 24, so I don't get any points. My blood pressure is about 118 over 75. If I'm talking during this webinar, it's probably up to 160 over 95. So blood pressure is always designed to be relaxed and things of that nature. So make sure you measure it properly. So I get 1 point there. So basically my probability of heart failure, if I'm short of breath, is about 20%, you see. On the other hand, if you weigh, let's say 200 pounds and you have a body mass index of 34, you get 2 points. You're taking blood pressure pills. You get taking 3 blood pressure pills, you get 3 points, and you get your blood pressure controlled. And you're 75, you have 4 points. 4 points gives you a probability of congestive heart failure 70%. I'll repeat that. By having a body mass index over 30, taking 2 blood pressure pills, and be over the age of 60 years of age, and you're short of breath, the probability of congestive heart failure is 70%. So here's our steps you can do to help prevent that. Now, let's move forward. Let's work on this over here. So this is actually called a frailty score, and one of the things is that you can decide where you fit on this. And this is another slide. You've seen this many times. Are you number 1, very fit or active? Are you terminally ill? You can see if you're just sitting around. Unfortunately, your life expectancy less than 6 months. Be active. And I know Phil and his wife are on this webinar, and they work in retirement settings. And unfortunately, the last 2 or 3 years of most of our lives are spent in illness. And people have to go to the nursing home because they can't walk, they fall, or their memories are poor. They just can't look after themselves and things of that nature as well. So to me, the gift of walking, gift of mobility is such a beautiful thing. So if you're not walking, learn how. If you need to use a walker, terrific. You need some aids, get there. But keep yourself moving for as long as you can. And I'm sad to hear people say, well, because the gym is closed, I can't go, I can't do anything. Yeah, you can do a lot. One thing I shouldn't say is during COVID, when we weren't allowed to play tennis, I climbed the tennis fence in the park. And I guess I shouldn't say that, but I have a couple of scars from almost killing myself climbing. But I think keeping outside and being fit. Remember, if you're outside, you're 35 times less likely to catch COVID compared to being inside. So be outside as much as you can. This winter, I have winter gear for biking, and as long as the roads are dry enough, I'm going to be out there doing something, and I hope you are too as well. And when we get our app going, I'd love to see everybody. We'll let you know when we're doing some exercise, and maybe you either do it separately or together. I think the mindful exercise group on Wednesdays at 7 o'clock. We always start off with a little exercise session. I think the weight loss group on Tuesdays at 7 o'clock, both on Zoom right now. Everybody's welcome to join. And we're just starting a new group we call the Sugar Hour, the Sugar Brunch. It's going to be the first Saturday of every month. At 9 to 10, we're going to have a series of talks, interventions. It's going to have a little bit of exercise, a little bit of cooking. And I can't forget Aditi, who's made me a better cook. And we do that once a month on Sundays from 4 to 6. So everybody's welcome. You don't have to be a patient of Dr. Curnew's. You just have to be a person interested in your health, and we'd love to have you for any of these events. So you can look at your frailty scale and how to do something about it. I noticed Phil and his wife are out there. I'm not sure if they have any comments that they want to add to that, or anybody else as we go along. Be welcome to hear more from people.
Can you hear me?
Yeah, we can, Phil.
Hi, good evening. I don't have a great, I've got a rural connection here, so if it gets choppy or the thing, my internet is so-so. But anyway, yeah, thanks for remembering the seniors. And I know even exercise in the very frail helps them and decreases falls and increases their enjoyment of life. And that's why our government is spending so much money on getting physio and physio aids into every nursing home in Ontario. And that's only going to improve as time goes on because they're going to pump more money into it. But I think thanks with Greg's help, he's inspired Joanna and I. Here's Joanna. We just finished our vegan minestrone soup. But anyway, because we had a webinar today all afternoon. But anyway, the exercise and all the things we're doing, I think we can help prevent the heart failure. And it's intriguing, this ejection preserve, because that wasn't even described when I went to medical school. And now is it overtaken reduced ejection fraction in our society, hasn't it?
Yeah, I think it's, if you, I'll show you some of our clinic data right now, but I think it's going to be eventually 80% is going to be preserved or mid-range, and only 20% will be systolic dysfunction. So it's overtaking as we get older, more sedentary, more high blood pressure, more overweight. We're going to have more of this problem. I remember Joanna, one of our webinars, was talking about how to prevent falls, and we're going to actually come back to that because there's so much you can do to help that circumstance. Joanna, did you have any comments for yourself too as well? About,
I think well, this about congestive heart failure. I think, of the 5 top diagnoses in nursing home work, I think congestive heart failure is in that top 5%. Sorry, in that top 5 diagnoses. Like, it's so common. You have to look for it, but you'll find it. And then the other thing is that Dr. Curnew mentioned is it sometimes is difficult because when patients are short of breath, you have to be careful to diagnose if they have lung disease or heart disease, and it often isn't that easy. Those are my only comments. And thank you for this webinar. I think it's very timely.
Yeah, very timely. We had a session this afternoon. Actually, Peter Lynn presented it on, he was, I think, the drug company, it was a drug company sponsored, but they were talking about preserved ejection fraction, preserved heart failure, and the new, diabetic drugs that are you're going to mention, I think, later.
Yeah.
Yeah.
Stay tuned. We got more to talk about. Thank you for sharing that. Go ahead there, Frank. Oh, here you go. This is probably one of my favorite slides, and I think we'll all be talking about that. So heart failure as we get older is not a disease by itself. It accompanies being overweight, and overweight for many people leads to lack of exercise. So you have muscle atrophy, you're weakened. Also damages your kidneys. And when you get fat cells in the midsection, it causes inflammation. So we know that COVID, any virus, astrocercosis causes inflammation. Same thing too with just being overweight. Unfortunately, the leading cause of now liver cirrhosis is just being overweight or fatty liver. We talked about the heart, and Joanna was mentioning about the lungs as well. So when I see a person who's short of breath, who has heart failure, they usually have 5 conditions together, and to sort that out becomes a challenge. And remember is that you can't stop yourself from aging, but you can reduce the aging process by activity, by keeping your weight down, keeping your blood pressure down. And I think the best anti-aging drug that I know of, it's called activity. I wish you would do it more. And it's also the greatest antidepressant I know. And for many people, it becomes too late because they're just too full of arthritis. Their brains don't work, their bodies don't work, their kidneys don't work, they're anemic, they're sad, they're depressed. Families can't visit them, haven't been seen by people, their livers are failing, their kidneys are failing, their hearts are failing. So it could be a sad way of ending your life. But you know what? You can get better, and you can do something about this. My wish for everybody who's overweight is to lose 30 pounds. And I can do it, you can do it, and let us work together to find solutions for many of us. And to me, that is, and we're going to talk about this a little bit more, that's the best way to improve the Kansas City Questionnaire, to make yourself better. Next slide, please. And this is the Kansas City Questionnaire, 0 to 100. I think, you get 100%. So this is my only 100% I'm going to get in the next little while. And if you're 50%, if you're 75 out of 100, I think you understand what that means. It's just what it says. And so again, it's on the first slide, the first couple of slides. Fill it out, so I'd be curious to see. I predict that Joanne and Phil will be 100 at this point in time. But everybody else, go ahead and just tell me what your scores at the end of the game is and stuff like that. So I've seen some 55-year-old individual. I saw somebody who has a Kansas City Questionnaire of 33 today, young person, and it's sad to see. And that's a bad thing. Next slide, please. And this is again to you have risk factors, and then we can look at heart failure. I think we talked a little bit about this, but one of the things is that if your ProBNP is going up or it fails to fall by 30%, that's a bad marker. So this is a very good and powerful predictor of mortality. The Kansas City Questionnaire is actually is even more powerful predictor of mortality too as well. So it tells you what you stand. So you can spend the $8 and get the blood test, or you can spend 0 cents and get the Kansas City Questionnaire. In fact, the Kansas City Questionnaire is a better predictor than the BNP. But they both complement. And the reason why Joanne is saying it's hard to diagnose heart failure, because lots of things exist together. And so if the BNP is on the lower side, I have to think less about the heart, more about something else. Next slide, please. And this is a game-changing clinical trial. So Frank, tell us about Emperor Preserved.
Okay, Emperor Preserved. So yeah, now everyone is aware of the risks and dangers of heart failure with preserved ejection fractions. And also we talked about a bunch of ways that you can kind of monitor it and also try to track it yourself. We can talk a little bit more about treatment, and specifically Emperor Preserved. It's a clinical trial of this drug called empagliflozin. And currently the therapeutic options for patients with heart failure and a preserved ejection fraction are very limited. However, there are treatments of drug types called sodium glucose cotransporter inhibitors that have been shown to reduce the development and progression of heart failure in patients with type 2 diabetes, and also in another type of heart failure, which is, we mentioned a little bit before, it's the heart failure with reduced ejection fraction. And the purpose of this trial is to take the drug that's been shown to be kind of effective in those areas there and see if there would be effective with heart failure and a preserved ejection fraction. So they recruited almost 6,000 people, which is a lot of people. And then they randomized them into control and empagliflozin groups. And then they followed up with their patients for 36 months, assessing their health status with, believe it or not, the KCCQ. And then they also looked at elevated levels of indicators like the brain natriuretic peptide as well. So the primary focus, however, for the investigators here was looking at, specifically, it's looking at hospitalizations and cardiovascular death outcomes. But what we'll see later is that hospitalizations is something that we really want to focus on, because you'll see that this drug here really impacts hospitalization.
So the inclusion criteria to get into the trial was that you had to have an ejection fraction over 40%. Because if you have an ejection fraction less than 40%, we call that systolic or reduced congestive heart failure. And it's a different sets of criteria. And to get into the trial, you had to have a ProBNP over 300. If you were something called normal sinus rhythm and a regular heartbeat, you had to use a higher cutoff value. So just put that number in your brain. For most of us, is 300 for ProBNP, or roughly 100 for BNP. And we have to show that you had some structural changes of the heart. You have to show some thickening of the heart muscle, loss of elasticity. That's my job to sort that out by echo. Of course, you had symptoms. That means you're short of breath when you're walking. You had difficulty lying flat in bed because you're short of breath. You might have to slip on 2 pillows. You may have had abnormal chest aches, right? Congestive heart failure require hospitalization for heart failure, that you required furosemide or Lasix. So it had symptoms, and the criteria of that neurohormone test, it had to be elevated. In fact, this trial had trouble recruiting initially because we don't normally do ProBNP because it's a non-funded test in Ontario. So unless you're in the hospital where it comes out of a global hospital budget. And so they eventually looked for, and they had trouble recruiting. Then they looked for small places, and we were like the little train that could. We were the last people into the trial, and we were the largest recruiter in Canada. So I'm really proud of how our team did this really well. And I give Connor credit. He came to us, let's do this trial. And took 2 years to get us ready for the trial. And we had very little time to recruit, and we worked our butts off. And I thank Jen, Stephanie, Trish, and everybody else, and all the different team members, Stuart, others were all involved of all the paperwork and recruiting patients. And so again, you couldn't have too high or too low blood pressure, and you had to have a kidney function, GFR, of greater than 20. Think of kidney function between 0 and 100 as well. And if your kidney function is less than 20, that's really bad kidney function. You weren't allowed in the trial. So this was a game changer of a trial. Next slide, please. And go ahead there, tell us a little bit more.
Yeah, so speaking of like what you said, it was a game changer of a trial. What you can see here is some of the results that are displayed. So what they did in the study is they took total participants, which is again was around 6,000. You can see the distribution between male and female there. And they actually recruited a lot of people who are in class 2. So there's a New York Heart Association classification. Class 2 is, I believe, the second worst one. Sorry, not the second worst one, the second best one. It's still not good by any means, but the second best one. So most of the participants fell there. And then they distributed people into groups where one group would have empagliflozin and take that drug, 10 milligrams per day. And then you can see here, if you compare that to the other group, which is a placebo, you can actually see there is a difference here between outcomes. So you can see that out of the around 3,000 participants in each group, in the empagliflozin group, you have 7% that experience cardiovascular death, and then 8% in the other group that experience death as well. And this is a statistically significant difference between the two groups. So you can see that there's a slight increase there in terms of looking at death outcome. But if you look at hospitalization, well, you can see that there's an 8.6% to an 11.8%, and that's a little bit bigger of a difference. And it's only 3% there, but 3% of 3,000 people is still a lot of people. And you can see that 400 in a composite score of cardiovascular outcome and hospitalization, you have 415 patients who were either had cardiovascular death or hospitalization compared to 511 patients. So you essentially, by taking this empagliflozin, you can portray this as you've been able to save around 100 patient lives, or 100 patients from hospitalization as well.
This is how the trial shows it in a picture. See, on the top is that you saw it was a 21% reduction in the composite endpoint of hospitalizations for heart failure. It means you need to be going to hospital because you couldn't breathe properly, or you died because of congestive heart failure. On the bottom, you see just congestive heart failure mortality. So the impact on mortality is very small, but the quality of life or the hospitalizations for heart failure. Now, you're right when you mentioned that, Frank, that class 2, we divide heart failure between class 1, you're totally asymptomatic. Class 4 means you're short of breath, just lying in bed. Class 2 means that you can walk around, you can go get your groceries, but you get short of breath after a while, you know. Class 3 is just minimal activities that you can't do basic housework, you get short of breath. So these were people that are typically get short of breath with just going shopping, walking their dog too quickly and things of that nature. Would often have swollen legs. Next slide, please. So this was a game changer. This is for the first time that a trial that looked at people with congestive heart failure as their main illness, that you decreased hospitalization for heart failure. We have lots of other data in diabetes, for instance, that you can prevent heart failure. If you had diabetes, you actually can prevent the heart from getting worse. This works in diabetes and without diabetes. So diabetes has nothing to do with the effectiveness of this therapy. It was just initially discovered in diabetes. So this drug is no longer just a diabetes drug. It's a congestive heart failure drug that's good in and without diabetes as well. Next slide, please. And again, the number one reduction, as Frank put within there, was reduction of hospitalization for heart failure. And that's important. I don't want to be in the hospital. I want to be in the hospital less. And so that was reduced by, total events for about 21, but hospitalization by about 27%. Frank, anything else you want to say about this slide?
I think the one thing that I want to mention is this little thing up here. I don't know if you can see my pointer up here, the hazard ratio. And I wanted to maybe explain a little bit about how you can see a hazard ratio of 0.73. And what that really means is if you compare placebo to empagliflozin, the treatment drug, I believe what the hazard ratio in this case implies is that there's a 0.7 times as many or people who have the same outcome when they take the empagliflozin drug compared to the placebo, which is a significant amount less. So from in the statistical standpoint, you can see that empagliflozin is effective in reducing hospitalizations, at least for heart failure with preserved ejection fraction.
So the way I look at it, out of 4 people who are on placebo who get hospitalized, only 3 would be hospitalized if you're on the therapy. So you got rid of about roughly a quarter hospitalizations for congestive heart failure. And you know what? Decreasing the chance of by being hospitalized by 25% for congestive heart failure, kind of nice. So that's important. Now, this trial only went on for less than 2 years. So it's a relatively short trial. And you can see that the curves look like they're still expanding. So this was actually very, very exciting news. And now, when we say randomized controlled trials, if you just backtrack one slide there, is that this is a blinded study. That means myself as the investigator and the patients do not know what you're taking. You get pills. They look exactly the same. Half the pills, or if you're randomized, all your pills will be a placebo pill, a sugar pill. If you're randomized to active therapy, you got the active therapy. In fact, we tried to figure out who got what, and we weren't very good at it. We weren't bad at it, but and so it takes away bias in this circumstance. So this is the highest quality of science that you can do. Next slide, please. And here's some more data to look about this. So you can see that there's a small trend in cardiovascular deaths. The number one priority was a decrease in hospitalization for congestive heart failure. But if you look at total hospitalization, it's not as dramatic. So only 20% of hospitalizations are so related to heart failure. Most of these people get hospitalized for other conditions. They fall and break their hip, they have lung disease, they're anemic, their kidneys are failing, they get pneumonias, they get depression, they go to the nursing home. We have to treat the whole patient, and but this treats the congestive heart failure. There was a small protection of kidney function, and you can see that this helped prevent diabetes by a little bit, and it worked in and without diabetes, and total mortality really was not changed. So this is really, this drug is not going to make your lungs any better, but it's going to make your heart less stiff, and it's going to make you decrease the chance of being sick from congestive heart failure by about 20-25%. But you still have other medical conditions you have to deal with. And that's why the other aspects of knowing your lungs, not smoking, exercising, losing weight, controlling blood pressure, treating depression, preventing falls are very, very important. And as Stuart points out many, many times, the number one predictor of longevity is quality relationships. So don't forget that. So, but these are people, unfortunately, is that over half of them will not be with us in 5 years from now. So, so this is important to spend less time in hospital, and that's important. So big breakthrough in that circumstance, but we still have to have other breakthrough therapies as well. We need to worry about your lungs, your depression, your anemia, your other medical problems as well. If you smoke, stop smoking. If you're overweight, lose the weight. If you have high blood pressure, control it. If you don't know what your blood pressure is, get a blood pressure machine, and have good quality relationships. Next slide, please. And this is actually our look at, so this is what happened with we're starting to look more for congestive heart failure. We have a long ways to go. We categorized so far 500 patients with preserved ejection fractions and 200 patients with reduced ejection fraction. There's still mid-range ejection fraction risk of heart failure. So we're looking, and you'll see those numbers expand right now. And again, I'm really, really proud of our clinic. We were the little engine that made it. I remember that little train story way back when. They didn't want to let us in initially, but if you can get a couple patients, that would be wonderful. We were the leading recruiter in Canada and probably other parts of many places. We worked hard on this because we see a lot of congestive heart failure. And as Joanne points out, is that we don't recognize a lot of it, and we're recognizing more. So special thanks to Connor, who took the lead in this area, and I see Heather's on there too as well. She put some of her heart and soul. We all put our heart and soul in this right now, and what we got to do is work hard in this area. What I will say is that the Kansas City questionnaire in this trial only improved by about 2 to 3 points. So that's not great. Quality of life will improve a little bit by the medication. For your quality of life, the best thing to do is get movement, get the weight down. And I think those are such crucial factors. So my quality of life is best because of activity and losing 20 to 30 pounds. And if I can do it, you can do it too as well. Do it, do it, do it now. Next slide, please. And this slide, you've seen this before. This is a key issue. If your biggest problem is you're depressed, we need to work on that. If you can't walk, we'll help you walk, get a walker, get physio, get occupational therapy. Is that you have lung disease, we need to treat the lungs as best we can. But to me, I think that if I had picked a single most important thing in a person such as this, is losing 30 pounds. That is by far the most important thing you can do for your health. The second most important thing to you is of movement of some sort. If you're too sore to move, then there's swimming, there's recumbent bikes, there's different things that you can do. The medications are life-saving, important, but the lifestyle changes are probably even more important in my mind. And look at this, exercise and weight loss. Tell us about this.
Yeah, so now you guys are aware of the risks and dangers of heart failure. And as Dr. Curnew has mentioned so many times this webinar, because it's so important, we want to talk about exercise and weight loss. And in terms of exercise and weight loss, one of the best ways you can kind of do it is to just incorporate it into your daily lifestyle. So I believe this is a picture of the Dragon Boat team you were on, Dr. Curnew.
Yeah, I'll have to give that. This is actually at one time we all went to the Welland Canal and we rented two dragon boats, and I was in the dragon boat that came in second. So, and it was so much fun. I think that day I met up with Joanne and lovely husband. I think we went for a bike ride afterwards, if I remember correctly. And this is actually the team here. This is something called konjac noodles. Now, konjac noodles is something I learned from the weight loss team, and basically these are basically noodles that comes from roots, and a whole thing of container is only 25 calories. And so, I try to give up pop as much as I can. I drink something called kombucha now, which is basically fermented tea. It gives you that fizzy taste, and I get the antioxidants that way. I'm trying to think with that picture on the left. Oh, that picture on the left, that's basically a picture when we're on a seaplane out in BC in Vancouver. I'm just, the name escapes me where we were. So being out in the wilderness and things of that nature is being outside, being outdoors and things of that nature as well. So you can see that the best way to be active is to do it with somebody else, I think. And so please find a way to be active, even this winter time coming. Do it safely, do it well, do it often.
Yeah, and especially if you're doing things that you like or things that you love, it'll make it so much easier for you to live a healthier lifestyle. If you guys have ever wanted to try rowing or dragon boat, I know we have a Hamilton Harbor and there's a pier, and they offer, it's called Leander Boat Club. You should check it out sometime if you're interested in that kind of thing. I'm pretty sure they offer, you can go rowing in singles, you can rowing in doubles, you can go rowing as a team of 8, even if you want to. So it's good stuff. It's interesting stuff.
And I don't want to say how this is not easy, but it's actually fun. And I don't know if we're all going to be successful, but enjoy the journey. We had people on that dragon boat that never tried that before. I never was in a dragon boat before. It was kind of fun. We were supposed to row together. We had a little trouble doing that, but that was so much fun. But we had good, as a good splashing people. I'm a good splasher, and who would have thought that konjac noodles would become a staple in my diet at this point in time? And Canada has wonderful places to view and to be outside right now. So enjoy the journey.
Yeah. So I do want to recognize that if you are kind of like further along in terms of heart failure, you do end up having something called exercise intolerance, where your heart cannot keep up with those strenuous activities of the body because it doesn't really feel that well, can't properly pump enough to oxygenate the muscles that you need when you're exercising. And some symptoms of this, so in case you think you do have exercise intolerance, some symptoms of this is chest pain, discomfort in your left arm, back and neck, shortness of breath, and usually this is caused by the lack of oxygen that's passing by your lungs. But some exercises that you can try, even if you do feel these types of symptoms, is things like stretching or yoga or light aerobic activities like walking or swimming or cycling, or things that you can kind of like control your own pace that you're doing it at. A good example of this is something also called the 6-minute walk test, which also kind of fits into that same category as like the Kansas City cardiomyopathy questionnaire. You can actually refer back to that. We did a little bit of a talk about that in our previous video in predicting heart failure as well. But some exercises that you might want to avoid if you do feel like you have that type of exercise intolerance is just high resistance training. Nothing that's like super static or isometric, which means you're not moving your body while you're doing it. So if you think of a plank, you're holding your body there for a long time. So try to avoid those or anything that really makes you short of breath, that causes discomfort. Some discomfort, I think, is always like a natural part of exercise. Like if you go for a jog, there's a little bit of discomfort, but afterwards, it's always a good feeling. So, but if there's a tremendous amount of shortness of breath or a tremendous amount of discomfort, then that's something you want to avoid as well. And if you're looking for resources to kind of help you exercise, one great reputable source is our own YouTube channel here, Greg Curnew on YouTube. We have exercises that are actually led by a club that's dedicated to this. So we have videos on chair exercises that you can do, as we all are right now in pandemic lockdown, working from our offices. You can, do 15-minute workouts that you can fit into your lunch break or your breaks whenever at work. You can do warm-ups and cool downs before workouts. And there are also a lot of motivational videos on how you can kind of jump back into exercise or jump into exercise if you haven't been super good at exercising before. There's also a lot of really great like follow along home workout videos that are perfect for people who can't really get out to a gym, or if you can't go outside for whatever reason. And you can always just go on YouTube and just search up beginner follow along home workout. And there are tons of different options that are available. And if another option that might be available to you are apps. So if you're familiar with apps, there are apps called, like, for example, Freeletics, which is a really good calisthenics workout app. So it'll give you a whole bunch of different workouts that are for people at varying levels. And calisthenics are basically body weight exercises. So they're things that you can do without any equipment or very little equipment, and you can just do at home as well. So we've talked a lot about the benefits of exercise and the things you can do, but keep in mind, it's not, some important thing is to not overdo it and not get yourself discouraged, but to start slow, build it up slowly, and take small steps to try and improve your life. So pick activities that you enjoy, and if you have any questions, ask.
So we actually have a really neat video that Jerry and his team did about chair exercises. So there's 10 minutes there that you can do, and if you do 2 minutes 10 times a day, that's fantastic. Yeah, they're all doing something. Rubber bands or just taking cans of beans and doing a little bit of exercise with that. So and if you have trouble with balance, make sure you have a walker. And if you need to sit down, you sit down. And Angelo, I see Angelo's out there. Do you have any comments about what you do for exercise, Angelo, at all?
I'll open up my microphone.
Thank you.
Okay, and the video as well, I think. I'm a good walker. I try to do close to 15,000 steps a day. I walk briskly, but I'm learning a lot, and there's a lot more that I could do. And while I was shutting my camera, while you were speaking, I was actually walking on the spot.
Nice. And you can see is that, I just had an apple. I want to enjoy these sorts of times and things on nature as well. And I know Philip and Joanne, what do you guys do for activity? I think your speaker's off still.
We'll get our speaker on.
There we go.
Okay,
There we go. Our big exercises, we like to do this power walk. We have this route and we time ourselves. So we have a certain time. We like to try to beat the time and at least stay in the parameters. And it's a country walk. We live out here in the country along Lake Erie in Port Colborne. And it's 5K. It's a 5K walk, and we'd like to power walk. It's pretty flat. Sometimes you get high winds off the lake. That's our main exercise. We've been golfing. So we never ride. We always take a cart and walk.
We always walk.
I mean, we always walk. We don't use a cart. And
we ride our bikes.
And we ride our bikes. And but I think our main exercise is walking, power walking. And I have an Apple Watch that we can track my pulse And Joanna can track her pulse so we can make sure we're in our training range when we're walking.
So it's kind of interesting that, I first met Philip at a lecture I gave in Niagara area, and he wanted to put his heart disease at bay. And so he has heart disease and he's controlled it well over time. I'm not sure if you, Joanne and Philip, you want to share your age. How old are you guys? Are you 21, are you?
Yeah.
I'm 70. I'll be 71 in January, and Joanna's
68.
in Joanna's 68. Yeah.
So-
And
So Joanne, a little while ago, had some symptoms. We did a proper stress test to make sure she's okay. Philip, we keep an eye on his angina. Angela, how old are you?
I'm 78, going on 79.
Okay, so I'm the young guy at 62 right now in this group, and and I think one of the ways to make it to 100 outside the nursing home is that you need to be active in some way. Thank you for sharing that.
Well, also just one thing, Philip and I also, we used to do a lot of Tai Chi, but then with the pandemic, our Tai Chi classes were closed, but I still do it at home in our living room.
I'll get back into it when the classes resume. Hopefully, I haven't heard when they're going to start back yet, but I think that's good for us too.
And the Tai Chi, part of it is the exercise component, but also we share like tea together, and it's like the social connection and interaction with other Tai Chi members in the club. So I think that's very good for relationship building too.
Right. Now, Angelo, do you I know that Philip and Joanne do a lot together. Do you do your walking by yourself, or would you have to use it for social, or what else? What else do you do to keep
My
connected?
wife walks with me quite a bit, but I do probably twice as much as she does. I'm a lot more active, I think. My brother sometimes, but I don't mind walking by myself. I self-motivate. I feel badly when I don't walk. I have a treadmill at home, so when it rains, I get on a treadmill and I do sometimes an hour on it while I'm watching TV. So that's my main way of staying active.
Nice.
And I need to.
Yeah, good. Always feel better. All right, Frank, what else do you want to tell us?
We're approaching the end of the presentation, but I think there's a slide here about all these different videos that we have available on our YouTube channel.
So a couple of things to think about. We mentioned cardiac testing when that needs to be done. We use the echo to look at the heart muscle to see if you have evidence of a stiff heart or a weakened heart muscle. Keeping track of your health, I don't know why people don't do that better. And I think is that people say you have the information. Well, you know what? You are the quarterback of your health, and how to lose weight. How to manage diabetes. I think that's important. I really love the sugar club that we've done. Good things. One of my favorites, not on here, is what's in the blood. How to look at that. All this technology, how to use this stuff makes happy, and well-being activity. Hannah and others have taught me the power of positive thinking. And you mentioned Tai Chi or some form of relaxation. There's so much to do, and I really enjoy our time here. And please share this with friends, colleagues, enemies, all the above. Is that if we do a good job at this and you take an active interest in your health more and more, your quality and your longevity will go up. And yes, the medication decreases the chance of being hospitalized by about 25%, which is wonderful. Remember, only 20% of hospitalizations are related to congestive heart failure. Once you get older and you struggle with congestive heart failure, other medical illness are part of that equation as well. So I hope you enjoy some of these things. I thank Stuart, who really has brought this to a brand new level. That one that was on arrhythmias last week, wow, I felt like that was Star Wars. It's only 10 minutes long, but wow, was that well done. And all of them. that one that we did on the Kansas City questionnaire. I can't find an app for the Kansas City questionnaire yet that works well, but we have a working model of that through that spreadsheet that you developed. And thank you so much. So get your Kansas City questionnaire and take steps to make that happen. Next slide, please. So much to say. Frank, what are some of the things you want? What you learn from this this journey so far?
Oh man, I think one of the biggest things that I took away is that we have a lot left in terms of care for heart failure with preserved ejection fraction, and it was really interesting to see your discussion, and as well with Philip as well, about how you guys discussed about how so many years ago before they didn't even have this preserved or mid-range heart failure classification. So it was really interesting to see how we're always learning about new things and learn new ways about how to treat heart failure, and how we always have, I'm pretty sure the Emperor Preserved study came out pretty recently, like 2021 as well. So it's nice to see how we can use research and translate that into helping people.
Yeah, it said it usually takes a number of years after the research is done until changes clinical practice. My clinical practice changed the day of the trial was released. And all the patients that we had in preserved have been offered to go on an SGLT2 receptor antagonist. The 3 ones in Canada are something called Forxiga, Jardiance, and Invokana. They're all phenomenally good drugs. They lower your blood sugar, you lower your weight from 5 to 10 pounds. You pee out the equivalent of sugared water, a can of Coke a day. They help kidney function, they help heart function, and they prevent hospitalization for heart failure. They're not very good drugs to prevent a heart attack. They're drugs to prevent congestive heart failure and kidney damage at this stage. Again, like always, if you have any concerns or questions, or you want to let us know anything, put drcurnew232@gmail.com. Please have as many people as you can look at these things. These are important because this is your quality of life. My quality of life is so much better because I'm still curious, I'm learning. I have all these young minds around me that keep me going. And I'm pleased to say our website's starting to come back. And we still have a long ways to go. We make a bunch of mistakes along the way, but we just get up and move forwards. And Stuart, any comments or questions from people out there?
Not at the moment, no. But I just wanted to add my 2 cents in here. I think it's remarkable seeing all of this research, as Frank was sharing, how even in 2021, we're still coming up with new scientific trials which are informing patient care and influences the way that doctors, physicians are able to help people. I think that medications are remarkable for prevention, for management, treatment. But I always come back when it comes to congestive heart failure to the Kansas City questionnaire, which I learned about in the last webinar. I think it's just a remarkable way to sort of assess an individual's symptoms, their function, their quality of life, and sort of give a number to your quality of life, as well as identify your congestive heart failure and how it may progress. And that's certainly a good way to sort of get an individual motivated to start thinking about lifestyle interventions as well. I think exercise intolerance, the slide that Frank showed, is really interesting because it shows, the importance of making your goals smart, so small, realistic, and then building up to something rather than giving your 100% right away, because that will probably lead to you falling on your face quite a few times if many people find that demotivating. I know I do. So making sure that your goals are realistic to yourself and doing physical activity that you enjoy is really important. And I think with our final discussion here, we talked about the importance of doing it with others. It often makes it a lot easier and more enjoyable.
Well, I'm just going to end in saying that a good doctor or good patient treats well and takes care of themselves. A better patient, better doctor prevents congestive heart failure. So there's been 2 studies I know recently with the Kansas City questionnaire. So Forxiga shown to in people with preserved heart failure increases their points by 5, and Emperor congestive heart failure was about 2.7 or so 2 to 3 points. I'm sure that Angelo, Philip, and Joanne have a Kansas City questionnaire of 100% at this point in time. I hope that you take an issue, and the best way to treat congestive heart failure is to prevent it from happening in the first place. And I hope you go back to that initial webinar, get your Kansas City questionnaire, and look at that webinar, take that to heart. If you have congestive heart failure, there's a lot we can do to help. Again, is that make your healthcare team bigger, surround yourself with people that make you better, that you can make better. If we all follow that policy, life would be good, or this would be better. So I want to thank, and it's kind of interesting, and as that Philip said, when we started medical school and went into residency, there was no such thing as heart failure preserved. And it was just recently we got to mid-range. Now we have preventing heart failure at this stage, and that's the important aspect of care. What this pandemic taught me is that the best way to treat infection is to prevent from happening in the first place. Now, we're coming into flu season right now, and I urge everybody to get their influenza shot. Last year, there was almost no influenza. Remember, in Canada, it kills up to 60,000 people per year if we're not careful, and depending on the year. My hope is that, and we now is a trial called IAMI that took people who had a heart attack, and by getting the flu shot during flu season, you actually decrease cardiovascular events by a quarter, decreasing mortality by 40% or so. So again, inflammation is never good. You can be that from being overweight, from massive sclerosis, but getting any form of sickness. We now know that there's a new vaccine called Prevnar 13, which is a vaccine for against pneumococcal pneumonia. And if you do get pneumonia, you're never the same. And in this age group, over 10% of people unfortunately pass away from their pneumonia, but you'll never totally recover from this as well. So infections are important, avoiding infections and keeping yourself healthy, keeping your immune system strong. And if you have congestive heart failure, that SGL2 receptor antagonists are one of the foundational therapies for heart failure. And this trial, which we were pleased to play a small role, it has changed my practice, but also reminds me that there's so much more to do. I thank everybody. Stuart, I'll give you the last word. And unless Frank, do you have any final words of wisdom? And I want to thank you for all your hard work. Like always, great job.
Yeah, I just want to maybe say it's interesting, like you mentioned, about how, we're always learning about some things, but I think some things will always stay the same, like exercise, and how exercise and diet and keeping track of your weight and keeping that weight low will always be helpful in terms of your health. So it's interesting how there's always that like foundational level of what can contribute to your heart health.
So if you have congestive heart failure, one of the recommendations is to weigh yourself every day, because you're gaining more than 2 to 5 pounds. You could be accumulating fluid. I weigh myself because I want to make sure I don't gain weight. And then when I stop weighing myself, I'm eating too much. So it helps keep me in check. So a good scale, good blood pressure machine, some form of step counter. I use a Fitbit too as well. And right now, Participation Canada is doing a walk across Canada that we're participating. Stuart, I'll give you the last word.
Yeah, well, I just wanted to say thank you, Frank, for doing a really wonderful job with this presentation. I know that this is a little off topic, but I just wanted to also touch base on, let's not underestimate the benefits of getting a good night's sleep as well. We did a phenomenal webinar on it a few months back. You can certainly find it on our webpage. But when thinking about the context of your health in a holistic view, it has tremendous benefits on your immune system, management of weight, boosts your mood tremendously, cardiovascular protective effects, increases your performance when you're exercising, consolidates your memory. Really, it's a wonderful thing, and getting a good night's sleep at the end of the day, especially after a good workout as well, is crucial to sort of recharge your batteries and start the day fresh the next day.
Yeah, thanks for actually after that webinar, I really put more emphasis on getting better sleep, and absolutely. Good point. So much to do, so many different areas. Listen, we all bid you good night, and thank you so much, and look forward to future presentations and learning. Thank you so much, everybody.
Good night, everyone. Take care.